Hi, so for number one, Mr. Jenkins just underwent a right total hip replacement, which places him in acute phase in acute inpatient care setting. Since he has a THR, he currently must observe not going past 90 degrees hip flexion, avoid hip AD deduction beyond midline of the body, and avoid internal rotation because that might open up the suture. He currently has right hip pain around the suture area, which is expected. His activity limitations include weight bearing in the involved limb and lifting restrictions. As for participation, limitations include no resistance or weighted exercises. Um, but you can introduce that, but gradually though. He can ambulate every day for at least 10 to 20 minutes per day to maintain vascular circulation on the involved limb. Question number two, the only lab value that I find alarming is his INR, which is the International Normalized Ratio. It's 1.2. The normal range is between 0.9 to 1.1 for adults. However, since he was on Coumadin, which is an anticoagulant, 4 days ago, that could be the reason why his clotting level is high. Question number three, since his mental orientation or alertness is slightly limited due to the anesthesia from the surgery wearing off, I would have to let Mr. Jenkins know that whenever he feels pain with certain exercises or he's feeling dizzy or lightheaded, that he let me know right away. I would also ask Mr. Jenkins um, for his RPE, his rate of of, rate of perceived exertion after each exercise activity. So checking in on him after each exercise or each intervention is crucial. This way we are aware of how difficult it is for him as far as cardiovascular wise. Um, question number four. I would ask Mr. Jenkins for his pain level at rest and pain level during the interventions. I would also ask about his functional limitations. Which activity does he have difficulty with? This could be pushing a door open, opening the door handle, or turning the door handle, holding onto the walker during ambulation. Asking him this will give me an idea on which muscle groups are weak and limited. Question number five, monitoring his heart rate and O2 saturation, bed mobility assistance level, ambulation assistance level, and verbal and tactile cueing will be important, pertinent, objective data collection with Mr. Jenkins. Last, number six, if Mr. Jenkins tells me that he can't breathe or he's showing fast respirations, I would stop the treatment. I would check his vitals and then consult a nurse. If his vitals are high, such as O2 sat beyond 100%, I would have him sit down, rest for 2 minutes, and check if his O2 sat level has gone down. If his alert level has diminished and he can't follow my 1-2 step directions, then I will definitely hold treatment and call the nurse right away because mental alertness, cognition, uh, orientation is very important um, with any patient. You don't want a patient um, that can't follow your directions, even the simple 1-2 directions. So you can't continue with treatment in that scenario. And that is it. Thank you so much.